Thank you very much. Thank you again to the organisers for the invitation. I will try and speak a little more slowly today than I did yesterday. My presentation will be around our experiences and our research in the rehabilitation of athletes presenting with athletic groin pain. And whether you work in Paris or Bordeaux or Lyon or Dublin, when it comes to athletic groin pain and you go into clinic tomorrow morning, we're all faced with the same challenges. Many athletes, as has been highlighted earlier on, continue to play and not report symptoms until they're no longer able to participate. There's a challenge in the clarity of the diagnosis and how best to intervene. As has been outlined in a number of presentations, is there actually any pathology at all? And therefore, what's normal in radiology or ultrasound and what's abnormal, and how does that influence rehabilitation? If we give a particular diagnosis, how does that influence my management strategy and what I'm supposed to do for rehabilitation? Often there can be inconsistent outcomes. Some athletes get better quickly, some slowly, some not at all. So tomorrow morning when we go to clinic, what are we supposed to do? How can we try and concise and improve the consistency of our outcomes? You'll have seen many beautiful cadaveric images over the last all morning, and they're rarely as clean cut as these images here, these animations. But when we're in clinical practice and the athlete identifies the source of pain and they press on this area here and they say, ouch, that's my pain. That's when I'm playing football or hockey or whatever, that's where I get my pain. What kind of problem is that? Is that a pubic problem? Or is it an abdominal problem? Or is it an adductor problem? And if I go 5 centimeters or less, 1 centimeter north or 1 centimeter south, is that a completely different diagnosis, and does that require a completely different surgical or rehabilitation management strategy? And what happens when we have pain in multiple different areas? We had a player, we reviewed an international player just 2 weeks ago, who was told that he had long-standing groin pain in this region. He was told he needed a steroid injection for his pubic bone edema. He needed a hernia repair for his inguinal pain, and he needed an adductor release for his adductor tendinopathy. So that's very bad luck. You start off with one pain and you end up with 3 different problems, all needing different approaches. Or are we confusing things and that we're just overloading this area for many of the same reasons? The Doha consensus, as Per highlighted earlier on, has tried to offer clarity around the terminology and group them into the various entities, iliopsoas, inguinal, adductor and pubic. And that takes away some of the miscommunication and misconceptions around that. From a rehabilitation point of view, it still provides a challenge because if we have pain with a number of different sources, how do we identify the primary entity and how do we rehabilitate that? Almost a third have multiple sites of symptoms. And number 2 is because I give you a specific anatomical diagnosis, does that mean I understand why you develop symptoms? If everyone on this side of the room has adductor-related pathology, does that mean that you all move exactly the same way and you've all developed the symptoms for the same reason, and therefore my rehab program will work the same for all of you? If everyone on this side of the room has developed pubic-related groin pain, does that mean that you all move the same way and you've all developed your symptoms for the very same reason, and therefore the same physical intervention should work for everybody? Very commonly, the adductors are the main source of targeting and focus and often get the blame. They're very, very commonly the source of symptoms, as outlined in some of the epidemiological studies earlier on. In one way, it makes sense that people will blame the adductors. Again, when you do your squeeze test, it's primarily your main pain provocation test is extremely useful and has been shown so in prospective monitoring of your athletes. But that loads a number of different structures concurrently, from your adductors to your pubic bone to your iliopsoas, all concurrently, so it's hard to differentiate. And often just because I have pain or I have weakness on a squeeze test, is that because I have weakness of the muscle group, or how much of that is attributable to pain inhibition? And if I took away the pain, that strength or that intensity of squeeze would return. I won't spend too long on this, as Andreas will be presenting on it after this. But adductor strengthening has been shown in this excellent study to be able to reduce the incidence of groin injury. However, when the injuries were broken into all groin injuries or those that have substantial problems, who had substantial time loss, adductor strengthening influenced and reduced the rate of all injuries, but not those with longer standing symptoms or more severe groin injuries. That's not to say that adductor strengthening is not a problem, but maybe it's not the one all solution in terms of reducing these long-standing groin pain patients that we see. And then we have the surgical approach, which is I have my adductor is overloaded, therefore if I release the adductor, that will reduce my symptoms. But if the adductor is as important as we say it is, which it undoubtedly is during sprinting mechanics, kicking mechanics, why would I cut it? Why would I reduce its function? If we try and draw a comparison with somewhere else in the body, if we look at the shoulder here, if we look at the glenoid, not the healthiest looking supraspinatus tendon, if someone presented with shoulder pain on movement, would you cut the supraspinatus tendon in order to provide relief? You probably wouldn't. So why would I cut or release my adductor tendon? Is the load or the traction the problem, or is the way I'm moving resulting in overload in that area? But it's not just the adductors. We're all told that we need improved core stability or core strength, despite the fact that very often it's overload of the rectus abdominis and at its insertion that drives pain. These are the athletes that tell you, I get my groin pain when I'm doing my core work. So what's the obvious solution? Well, I do more core work, and therefore my groin pain gets worse and worse all the time. Is it that the rectus abdominis is weak, or is it the way that I'm executing these exercises, primarily through my control of my thoracolumbar and lumbopelvic sections, that's resulting in overload at a small attachment area rather than the distribution? Is it weakness or insufficient optimal distribution of load? Because our obliques are our anti-rotation and anti-tilt muscles. And you can even see anatomically how they sit perfectly in the axis of rotation. The rectus abdominis doesn't. It is a small attachment, very defined attachment area sitting at the front of the pubis. And therefore, the more overactive and dominant it becomes, the less function I have, but also the more likely I am to lead to overload injury in this area. So does more and more rectus abdominis strengthening solve or resolve the problem? And then we have the inguinal group, the hernia group. Many of the research papers will say there is no such thing as a hernia. Even with a good few beers tonight, you would fancy your ability to be able to make an accurate diagnosis here. The most obvious thing, again, this is a very, very clear-cut direct hernia. The most interesting thing is the vast, vast majority of these presentations are completely asymptomatic. They don't come to us because they've got groin pain. They come to us because they're afraid their third testicle has arrived. And therefore, how is it that we can expect that subtle weaknesses or micro tears, as is often reported, are leading to these chronic long-standing symptoms in athletes, when very often the majority of athletes, or slightly older males, will present completely asymptomatic with the arrival of the third testicle? It doesn't make sense. So are we looking at specific pathology that needs to be fixed or released or repaired, or specific structural deficits that need to be overloaded or strengthened further? Or are we looking at a biomechanical overload that's leading to the production of symptoms in this region? Does the anatomy or does the diagnosis matter? Have we an over-focus, as Andy alluded to, an over-medicalization? Are we overly focused on the source of the symptoms rather than why have I developed symptoms in that area? And how is that going to influence my rehabilitation strategies? Like all things, if we stand back and listen to our patients or listen to our athletes, they'll very often tell us what the problem is. They'll say that at rest I have no problem, straight lines or cycling I have no problem, but when I'm doing high-speed maneuvers or high-speed multiplanar activity, I get my groin pain. When I go to decelerate, when I go to take those first 3 aggressive steps, when I go to take that long crossfield ball. So if they are telling us what the problem is, we need the skills and the clinical reasoning and the coaching skills to be able to assess these movements. But also we need to have the skill set in our repertoire. We spent all day yesterday talking about analysing movement and how complex motor learning is, and how the problem is not the knee, it's everywhere around, and how we influence that. Whereas a lot of today is around focusing on a very small area rather than those global movement strategies. So can we assess these movements and can we change them? Andy highlighted this animation earlier on about how is it possible that how we move or control our thoracolumbar region may result in symptoms in the area. Well, again, any change in my pelvic position is going to influence how I preferentially load my rectus abdominis. Any loss of center of mass control relative to my stance leg is going to influence how I load my medial groin. How I dynamically impinge my hip joint is not going to lead to not only hip load, but also the transfer of load through the superior pubic ramus. As was highlighted earlier, why have we such a high co-prevalence of musculotendinous groin pain and hip-related pathology? Is they separate entities? Is it genetics? Are mum and dad to blame? Or how much of it is to do with the very, very common movement strategies? If we strip back the muscles and tendons and look at that anterior pelvic tilt or loss of femoroacetabular control, we're going to get dynamic impingement. The more I pinch a joint, what happens? The more bone is laid down, and so on and so forth. And so I might go for my hip arthroscopy, for my asymptomatic FAI, that most of my pain-free colleagues also have, and just go back to exactly the same movement strategy again and wonder why my adductor-related pain or pubic pain has continued to exist. So our approach in Dublin has to be trying to take a step back and focus on the overall movement strategies and how best to assess these, and then also how best to intervene with them in our rehabilitation. Again, exercise in the management of groin pain is not new. Per has proven this almost 3 decades ago, that exercise therapy works for these athletes. But do we need to look at specific rehabilitation programs depending on where the source of pain is, or can we take a more global approach? So building upon the papers, diagnostic and cluster that Andy shared with you earlier on, we looked at rehabilitating these athletes not based on where their anatomical source of pain was, but focusing on their intersegmental control. So putting all the adductors, all the pubics, all the abdominals in a singular group. The rehabilitation program is focused on working on their motor control, in particular in relation to segmental control, such as compound lifts, progressing on to linear running mechanics, and progressing further on to change direction high-speed movements, which ultimately is the type of movements that they're going to be returning to when they go back to the field of play. Progression through this program is based very much on individual response. Again, all day yesterday we discussed about how athletes learn to move differently, how they respond differently to exercise interventions. So your progression through this program is based on not that everyone is going to do a front squat, but based on your movement competency, how quickly can we progress your technique, and how are your symptoms responding in advance. And these were all semi-elite athletes who had 1 rehab session every 2 weeks for progression of their exercises, going from level 1, which is intersegmental control, to running mechanics, to change direction mechanics. The exercises focused, as we said, on compound lifts with our front squat, our deadlift, and our lunge, focusing not only on lumbopelvic control, but also the often neglected thorax as well. Working on abdominal strengthening and trunk strengthening that biased the oblique musculature, especially the external oblique. Not that we didn't want to strengthen the rectus abdominis, but we wanted to restore balance around the trunk. Progressing on to linear running mechanics, where we can work on trying to maintain neutral pelvic position. But if you watch the stick, can you see how much stick rotation he gets while skipping, and how that's going to influence loads, especially through that inguinal and low abdominal area? So I can go back and fix the area, but if I'm returning to the same mechanics, what's stopping me from continuing to overload it going forward? And similarly with change direction mechanics. We had some lovely presentations yesterday on motor learning and motor control. The best drills are the drills where you shut up. You just pull the band, be as explosive as possible, and let them come up with an advanced or an evolved movement strategy that involves keeping his centre of mass within his beta support. So the outcomes, 73% made a pain-free return to play. Again, the pain-free is important. We talked earlier about those that can continue to play or return despite ongoing symptoms. 16% withdrew because they were able to return to play but didn't finish off the study. 9.9 weeks for return and improvement across Hagos scores. But going back to the diagnostic element of it, there was no relationship between the anatomical diagnosis and the time to pain-free return to play. So whether you were adductor or abdominal or inguinal, that had no influence on how quickly you made a pain-free return to play. Similarly, there was no relationship between the duration of your symptoms before rehab, all long-standing groin pain, and how quickly you returned. So if you had symptoms for 6 weeks or 12 weeks or 24 weeks. So if where the pain is coming from doesn't influence or isn't related to how quickly you return, and how long you're sore for doesn't influence how quickly you return, perhaps it's the way you're moving and how quickly we can influence those movement strategies that's going to lead to a pain-free return to high-intensity multiplanar sport. Also of interest were the biomechanical changes that we saw pre to post rehabilitation, with reduced hip abduction, reduced trunk side flexion, reduced hip, knee and hip flexion, and shorter ground contact times. So in other words, they kept their centre of mass more towards the base, within their base support, and were more explosive off the plate. Similarly, in the transverse plane, there was less trunk rotation away from the direction of travel and less foot rotation as well. So that's change direction. One of our other colleagues, Shane Gore, wanted to look at hopping mechanics and our ability to control stiffness, how much we deformed during a hurdle hop. So he looked at athletes pre, post, and compared to controls, and looked at the difference in joint stiffness across multiple planes during a hurdle hop. What he found was there were 3 variables that were different from those who were groin pain and those healthy athletes that had no groin pain, which was vertical stiffness, ankle plantar flexion stiffness, which is Andy has highlighted earlier on, and hip abduction stiffness or pelvic drop. Of interest, when we looked at pre to post rehabilitation, only hip abduction stiffness went back to normal or was similar to the normal groups, despite the fact that athletes had made a pain-free return to play. So maybe ankle stiffness is something that we need to, and what we have, continue to evolve our rehabilitation practice to influence and improve on those outcomes. Data that's just fresh off the press, our colleague Sam Beda is doing his PhD in athletic groin pain with a particular interest in movement variability. He's just repeated the study with 42 groin pain patients and 36 healthy controls, again long-standing group, and expanding our analysis to also look at handheld dynamometry, range of motion and explosiveness, as well as our common biomechanical variables and some unique tests looking at repeated hops and movement variability. He found similar outcomes in terms of pain-free return to play and return to play times. Again, large effect size differences across the HAGOS, and those effect sizes were maintained when he followed them up at 3 months and at 6 months. Interestingly, no difference in hip range of motion, whether you're a control or before or after rehabilitation, and no difference in abduction to adduction ratio. So on handheld dynamometry, there was a very similar or exact same abductor to adductor ratios between those that had no groin pain and those that didn't and rehabilitation. Of interest to us is the improvement of strength as measured by handheld dynamometry around the hip and pelvis. There were large effect size changes in hip abduction, adduction, extension and flexion strength post-rehabilitation. This is the normal group here. This is pre, this is post, so a large change pre to post. There's no significant difference between post and normal, but maybe some area for ongoing development. Of even greater interest is the fact, despite that we did no specific adductor strengthening work, that there was complete resolution back to normal levels of adductor strength post-rehabilitation. Again, that's not to say that there wasn't indirect adductor strengthening through some of the compound lifts, but how much of restoring intersegmental control led to a resolution of those reported adductor weaknesses. So just one last video. When we look at this athlete, he's not an athlete, he's one of the physiotherapists that work at us. He is an athlete. He would be insulted if I didn't call him an athlete. And we look at his mechanics and how that might relate to groin pain. What side do we think, hopefully, he might be susceptible to developing groin pain? Where we're looking at his thoracolumbar control, we're looking at his lumbopelvic control, perhaps we're looking at his foot and hip rotation and noticing that right foot externally rotates a little bit more, but that's a very slow compound movement. So we try and bring him into a unilateral assessment. If we look at him on single leg on the right-hand side, again we see some hip adduction, pronation, internal hip rotation or rotation of the pelvis on the right side compared to the left side. Probably better than he is on his left, or probably worse than he is on his left. And then we come to his change direction mechanics. So if we have a look at him change direction off the left-hand side, probably many features you would like. Good trunk angle, good foot position, short ground contact times, nice and explosive. But if we have a look at him change direction off the left, or off the right side, quite a different movement strategy. Foot external rotation, trunk rotation, knee valgus, and it takes him 2 landings to try and make the change of direction. Now, does that mean that hip strength alone is responsible for that? It's highly unlikely, because not only does he need the capacity to produce force, but he needs to be able to produce it at high speeds. You can clearly see he has an eccentric rate of force development deficit there because it takes him 2 hops to resolve. So if we did strengthening work, and if we did rate of force development work, would that be appropriate? It would help, but maybe that's the movement strategy that he's adapted or accepted to change direction off his right side. So it's chicken and egg. Which comes first, the weaknesses or the desired motor pattern? And from a rehabilitation point of view, we believe the most effective way is to target all of these things concurrently. As Andy said, many of the normal athletes are retained within cluster 1, and we're finding that those positions of trunk rotation and side flexion, hip abduction, move more and more towards cluster 3, sorry, post-rehabilitation. And our future work is focused not only on change direction, but looking at high-speed running and sprinting, and how that might also finish some of our understanding of movement and overload in the region. So when I'm looking to rehabilitate someone with athletic groin pain, or any injury, ACL, recurrent hamstring tendinopathies, it's not enough to look only at where the pain is coming from, but also look at all the factors that may result in overload in that region. Because I may have 5 athletes all presenting with pubic bone edema or inguinal-related groin pain or adductor-related groin pain, but all presenting looking physically very, very different. So if I give them all my adductor program, some will get better because that's what they needed, some will get better slowly because that's some of what they needed, and some may not get better at all because that's not what they were needed and may only reinforce where they were overloaded to start off with. One final point is about failing rehabilitation. One of the key criteria often for surgical intervention is that I failed conservative management. What does it mean to fail rehabilitation? Have I failed, or has rehabilitation failed me? Have I failed to identify all the contributing factors why I'm becoming overloaded in that region? Or more importantly, or more concerningly for me, has my program, the exercise I selected, and the way I've coached those exercises not got the desired change? What does it mean to do 6 or 8 weeks rehab? It doesn't mean anything. It doesn't mean that I was training at an intensity to improve my strength. It doesn't mean I was training with a coordination and technique that led to improved motor control and transfer onto the field of play. So rather than sort of saying, I failed rehabilitation, identify what you want to achieve, similar to ACL rehabilitation, achieve those outcomes, and then if you have ongoing symptoms, then perhaps you can review anatomy. So, does the diagnosis matter? Of course it matters. You don't want to be rehabilitating something that's a pubic bone or stress fracture of the neck or femur or something more sinister. However, does the diagnosis matter when it's coming to decide what I need to do to rehabilitate this athlete? It probably tells me very little. Can we change our focus away from the source of symptoms and more specifically towards the source of the problem and why I'm developing symptoms in that area? Can I individualize my approach to that athlete and not to their diagnosis? Have I identified all contributing factors, from strength to power to rate of force development to running mechanics to change direction mechanics? Has my rehabilitation and how I've coached those exercises led to effective change? And we're missing or haven't purposely discussed the key factor here, which is external load. We have athletes who move well, who develop groin pain. We have athletes who move what we would describe as poorly and never develop groin pain. External load is obviously the key factor here at all times, but from a rehabilitation point of view, what can we control? Thank you very much.